Well, good afternoon. Pleasure to be here after lunch for it. My name is John Demore. I serve as President and Chief Strategy Officer of Diameter Health, and excited to be invited by NCQA to help moderate this panel. I plan to be sitting, but I will be standing due to lack of lanyards for that. So excuse me as I kind of turn to our panelists and ask questions from the podium, but this is really their stage and their opportunity to speak on this. Just to frame up the discussion, the title of this session is eCQMs and ECDS, taking the next step of bringing quality measurement to the next level for it, through digital innovation. And when I want to ask the question first, what is digital innovation? There's certainly no one answer to that. But I look back over the past decade, go from 2005 to 2015, to see the change in the landscape for electronic health records. And it's been immense. It's been a step function for that, where we've gone from under 25% adoption to over 85% adoption if you bring this to today's numbers. As Michelle mentioned, they have a few years lag of getting out the numbers for this, but certainly over 90% ambulatory EHR adoption today. And the vast majority, virtually all hospitals being on electronic records. So the program, known as Meaningful Use, has been tremendously successful at creating a digital infrastructure for clinical information for that. And I have had the opportunity to work with large numbers of organizations that are innovating and that are unleashing the potential for that digital innovation at a local level. I had the opportunity to work in upstate New York, working to do opioid research, looking across multiple emergency visits and seeing patients that might have drug-seeking behavior. Having the opportunity to listen in to the Physician Payer Quality Collaborative in Michigan, where all of the major health systems and all of the major payers are sitting at the same table working on how they exchange clinical data so that they can appropriately calculate quality, as well as also close care gaps and get that information back into the workflow. And thinking about Ohio and Kansas, where they're building the infrastructure to be able to do quality measurement when you have hundreds of sources of incoming data. That local innovation is happening. The future is here. It's not evenly distributed to this. And when we think about what's happening at a national level, there is progress being made, significant strides being done through NCQA, through this event, through things that CMS are doing, but there still are obstacles. There still are roadblocks, which our panelists will speak to, as well as the promise and the opportunity that's being realized. I'm excited to go after Michelle because she actually helped cue up this slide a little bit of the acronym soup, or the acronym bingo if you prefer. When you think about the spectrum of quality measurement, you think about providers and health systems, and you think about all the different programs. I've only listed a subset that they have to participate in. So you think about accountable care organizations and alternative payment models. You think about the MIPS program, the Merit-Based Incentive Program that's part of MACRA. You think about things from the patient-centered medical home model, as well as things from an inpatient quality reporting, a readmission reduction process. The number of quality programs is large and has grown significantly over the past decade. When you think about exchanges and health information registries and quality centers, there are programs like QCDRs, Qualified Clinical Data Registries, that are capturing information from multiple sources to be able to both create new quality measures and to report on the quality performance of providers. There are state registries and state programs that are out there to be able to collect data, some of them being anchored around Medicaid programs and health plans for it. There are also medical societies that operate both at a regional but also a national level for being able to calculate care quality and provide that feedback to clinicians to be able to have that continuous improvement, that learning healthcare system. And then when you go over to payers, auditors, and employers, there's certainly HEDIS, which is certainly the largest one in the room here for thinking about the health effectiveness data and information set for it. There's the Medicare STARS program, as alluded to by Michelle for that. And also how payers are also sponsoring patient-centered medical homes for it. Again, this is just a sampling of this, but when you think back to the title of this panel and what we're going to be talking about, we're talking about eCQMs, which often span on that provider-reaching side of the market, as well as ECDS, or electronic clinical data systems, which spans more to the payer and the employer side of things, and thinking about all the ranges of where quality is measured. But let's forget all this for a moment and back up to what's most important here, and really what Michelle was talking about for focusing on how do we actually do this of improving patient care. When we're looking at the patient, they don't know that all these programs exist. They don't know that their physician has to click on that little cog or that place in the worksheet. They want to just be able to say, what are the things that I need to ask? What are the questions? How do I get good quality care? Before we had EHRs, we could only ask a certain limited number of questions. They were good questions. Was a test ordered for a particular disease state, like HbA1cs for diabetes? But once you have the EHR, once you've unlocked that clinical potential, you can actually say, does that result show good control? Is this patient doing well? Using pharmacy data, which we've had for a long time, you can ask, are patients who are hypertensive getting medications? Are patients who have hyperlipidemia getting medications? But now we can begin to ask, are those drugs actually controlling blood pressure? Are they bringing down the LDL levels? You can ask better questions, and Peggy really chimed this up this morning, thinking about how can we begin to stratify measures like mammography, and thinking about that on a risk-adjusted basis using this clinical data. We can ask, did the patient go to that office visit they were supposed to go to? That was always available to ask based upon billing data, but now we can actually ask, are the right preventative care treatments being provided and the services for that patient? Are they getting their eye or their foot exam as appropriate? So I'm truly excited to host this panel, to ask some questions to each one of our panelists for it. They have perspectives along this whole spectrum of how you exchange data, bring it from point A to point B, how you audit data, how you talk about the veracity, the correctness of that information, to make sure it's fit for purpose when you put it into quality measurement and ultimately quality improvement. How do we actually perform the measurement based upon that data? And how do we communicate the results back? How do we communicate those results to clinicians? How do we communicate it among plans? How do we communicate it to the patient? We want to use this data to be able to improve that spectrum of quality care being provided not just to PCPs, not just of hospitals, but across that whole spectrum, including specialists, referrals, long-term acute care, post-acute care for it. And ultimately, how do we innovate? How do we take those local innovations that we're beginning to see emerge and continue to accelerate that? How do we reach that tipping point? Each one of our panelists will have perspectives to share on this, and I'll just introduce them as we all together right now, and then we'll actually have them go across. So the first person that we have is Leah Maves, who is director of the NCQA programs for the Advent Advisory Group. Each one of our panelists has a great bio, and I'm not going to read the whole thing, but that's available on the website as well as in your app for it. Then we'll have Ginny McLaughlin, Senior Quality Management Analyst from Blue Cross Blue Shield of Alabama. We have John Glaser, all-powerful, all-knowing for it. Senior Vice President for Population Health at Cerner, and previously having worked at Siemens and also Partners Healthcare here in town. And Ken Mandel, who serves as Director of the Computational Health Informatics Program at Boston Children's Hospital, as well as being the Lindbergh Professor for Biomedical Informatics and Pediatrics at Harvard Medical School. So to get started, we'll go in order here. For Leah, the largest program for value-based care in the United States really is HEDIS. Billions of dollars flow on that, and Advent serves as one of the leading auditors of that program. How has the adoption of EHRs changed the way which you look at clinical data?
Yeah, it's a great question. So clinical data has been part of HEDIS since hybrid was introduced. We look at medical records one by one. So clinical data has been there for a very long time. So what we're really talking about is the shift of one-by-one abstraction to be able to query clinical data in electronic medical records. It's very different. Unfortunately, right now, we're at the peak of burden. I know that's what all the health plans talk about. We're at the peak of burden with being able to optimize that clinical data in the EHRs to pull it out, because you're doing one-by-one abstraction on hundreds, thousands, tens of thousands, those large plans, millions potentially of medical records one by one. That's a lot of work. But we're also trying to transition over to querying the electronic medical records and other electronic sources to lessen that burden. So what are we seeing in a transition? It's slow. It's definitely slow, but I will say that the health plans that Advent are working with, they're committed to getting that electronic data. And last year we had 2 health plans report the ECDS measures. This year we had 7 report the ECDS measures. 2 additional plans had attempted to report and were not able to. So definitely an uptick in interest. And we have health plans that kind of run the gamut of some that can't get the electronic medical records queried and into their data warehouses to be used for reporting, and some that work in integrated systems. I'm from Wisconsin, Madison, Wisconsin. So yeah, woohoo, whoever that was. Go Badgers. But if you're familiar with Wisconsin, the entire state works in systems. So our health plans own the hospitals, they own the clinics, they employ the providers. So we run the complete gamut of plans that can't get an electronic medical record, all the way up to integrated systems that don't pull a hybrid sample until March, and they do medical record review for 3 weeks, and then they're done at the end of April. So we see a lot of variability, and we're really committed to working with each health plan to help them progress.
So when you think about the plans that have been successful in bringing in that clinical data, are they doing so in a focused way and kind of limiting it to the hybrid measures? Are they limiting it to even specific measures within there? Or are they thinking more holistically?
Well, let me give you the honest answer. If Medicare plans are going to look at star measures, just in complete honesty. And so we see these measures that are going into parallel reporting for HEDIS 2020, which are colorectal cancer screening, breast cancer screening, and ADD. And those measures are very important measures in the Medicare reporting set. So of course, they're starting to look at ways they can bring in colorectal cancer screenings into electronic medical records. It's not necessarily always EHRs that they're looking at. I have seen health plans contract with Cologuard, and then keep that data in a case management system. So they're owning that, they're in charge of it, they have their colorectal cancer screening, they're gonna have easier data, they're gonna query their case management system, they've administered the screening, and they're gonna be compliant. So it's not necessarily-
Cologuard's one of the fecal samples?
Yeah, fit DNA,
Okay.
Yep, in the measure set.
Do you see the trajectory? So you talked about how 2 went through it first, and now we're up at 7, and a couple more that have tried for it. What do you see the participation rate looking like over 2020, 2021 as you look forward?
Well, I am forever the optimist. Ask any of my colleagues, they're over there. I think it's going to continue to increase. So we host a conference for our clients every fall in November, and we have a session specific to ECDS, and it was standing room only. So even though we only had 7 health plans that reported it this past year, everybody's very interested in it. Everybody's aware that this is where it is going. Advent is first and foremost an advocate for the health plans we work with, but we're also committed to helping them and educate everybody on how can you do this.
Okay. And thinking about how you do this, how does Advent, within the organization, work to ensure data quality and consistent standards for data? And then how do you even work across and think about what you do versus other HEDIS auditors?
So I think the best way that we ensure consistency is education. Not only education to our audit team, but to the clients that we serve, to the health plans we're serving. So as I had said, we do our client conference, and we have a session on ECDS, and we give handouts, takeaways to folks. Here's something you can, it's actionable. Everything we give out is actionable. You can take it back. It's not necessarily a white paper, because we can read that other places. What can you do? And then for auditors, for the ECDS auditors, we had 5 auditors across the 7 plans that were auditing the ECDS measures this year. And we did phone calls every other week to get together and say, what are you seeing? And then we created a worksheet with validations of the ECDS measures of what you should be seeing across the initial population, the denominator, the numerator, and potentially the exclusions within the measure, and then across the measures to validate that those measures are being reported accurately.
How do we get to a system that's taking this digital data without jeopardizing a lot of the things that are working?
Yeah, in my opinion, the million-dollar question. So I think the way to break it down is know that while we're talking about electronic medical records and clinical data within electronic medical records, there are 4 source systems of records within ECDS reporting. We call those SSORs. And clinical data, EHRs, is just one of them. We have 3 other ones that we need to leverage. So first and foremost, what we encourage our health plans is to not be afraid to try. There's no penalty in trying right now. In theory, breast cancer screening being reported between traditional HEDIS and being reported in the ECDS methodology should be exactly the same rate, right? Unless you have some crazy supplemental data source that you have implemented that can't fit into an SSOR, all of your administrative claims are going to come into that as well. So the only thing you could potentially do is maybe go up. If you have a case management system you're going to incorporate, your electronic medical records you're going to incorporate. So how do we get this going? In my opinion, just try it. It's not going to hurt you. And Ben, don't strike me down up here. But don't be afraid to just produce the measures and not report either. Get your toes in, see what this data looks like. Now, we encourage you to report it because it helps NCQA further build upon these measures and see what's going on. But keep trying and leverage those other data sources. Auditors know that bringing in EMRs it's very costly. It's a lot of mapping from one EHR to the next EHR because an EHR is not like any other EHR, and there are several instances of them. But taking off chunks at a time when we recognize how much work this is.
What do you need from the auditor's perspective, from NCQA, from HL7, from CMS? I'm going to give you an open ticket here to ask what you want to make this transition smoother, to help the plans you work with get on board and do this faster.
Well, I've already asked NCQA for this, but since you're giving me this audience to ask the question, I will certainly take advantage of it. A more distinct timeline. So when is this going to be required to be reported? I think it's important to note that we have selected Medicare STAR measures as some of the first measures to be parallel reported. And while we say that the traditional HEDIS measure is going to be used for incentive payments, have we started to consider what's going to happen when the ECDS rates are higher than the traditional and the health plans want to report and have their incentive on the ECDS rate? And requiring it, or just a measure, or when that's going to happen, is going to help these slow adapters to try it. So, and I think I'm probably speaking to people that are very engaged in this right now, but we need to get everybody on board, the timeline.
Thank you. So moving to Ginny. Again, thank you for being here, Ginny. From a payer's perspective, from a health plan perspective, where are we in the journey to digital quality measurement?
I would say that we're definitely on the right direction because digital quality measurement leads itself to being a byproduct of care and not necessarily extra steps. I think digital quality measurement is definitely where we know we want to go. But I would say from a payer, there is still a long way to go. Payers are grounded in data that's used for reimbursement. Our core business function is to pay for health care. But we are making a shift from being totally reliant on claims data to using more clinical data in our performance measurement, in case management, and overall population health.
Is it going too fast or too slow?
Well, one of the things we've always thought was too slow was the release of the HEDIS specs every year. I'm from the South, so if you want to say amen, you can. It's just really been a time crunch for us when the specs were released in July and then not finalized until October. At that point, we're a solid 9 months into the measurement year before we had final specs. So we were very excited when NCQA announced last Friday that in the coming years they are going to be providing the HEDIS specs earlier, preliminarily before the measurement year even begins, and then that traditional October update being more at the end of March. So it's such a huge help in the time frame. We have always felt after that October, I use air quotes because it's not going to be October for long, but in that time crunch before the measurement year ends, that just lends itself towards only the required activities getting priority. So we're hoping that being out from underneath that time crunch is going to allow us to really make more strategic and forward-thinking decisions with having more time.
And double down on that from the provider setting, having the eCQMs early in advance also helps from that perspective for it. How do you get data into the hands of providers to help close care gaps, which is non-compliance with the clinical quality measure?
Sure. So ever since the healthcare ecosystem started a transition to pay for performance, I think this is exactly what providers are asking for. They want to know who their members are that have gaps, how to close those gaps. They may see that a member from their documentation has had a recent colonoscopy and not know that the provider doesn't have that data. So I think providers want to know what is a real gap in care or a service or a screening that needs to be performed versus what is a gap in data. So I think getting that gap information, our plan is a founding member of the Da Vinci Project, and we're very active in those use cases, really excited about their new use case for gaps in care and getting that data to providers using FHIR. And one of the things that our plan has developed is what we call a patient management resource. It's a dashboard that lives behind our provider portal, and it shows information about an attributed or a provider's attributed patients, and their quality scores. It also allows them the opportunity to really select a certain measure and see all of their individual, that members' individual gaps, or maybe to see their members with the highest count of open gaps. They can target members that way. They can also there see a patient health snapshot, and that is literally a snapshot of an individual patient. It's generated or updated at every eligibility check. So the provider can see if a patient's coming in, what their gaps are, what their measures are, what the measures weighting in our scoring program is, and they can also see risk coding accuracy scores. But I think just at a individual patient level, that patient health snapshot has been really helpful for them. And then lastly, we send care alerts out to providers when an attributed member has been admitted or discharged from the ED or an inpatient facility, letting them know that a transition in care needs to occur. When we introduced that measure to our provider community, their complaint was, we didn't know our member was hospitalized, and so making them aware of that, I think, was a big step in letting them know that a gap has been opened.
Okay. And just because you brought it up, and I know that Michelle spoke about it, also Chuck spoke about it earlier, the Da Vinci program as a founding member, can you define that for the audience?
So Da Vinci is a payer-provider collaboration. There are 16 plans, 9 EHRs. I don't know what the latest numbers are.
But it's bringing both sides of it together.
Yes, it's definitely bringing the payer and the provider community together. We want a lot of the same things, and we're figuring out how to do things better in FHIR.
And for the acronym bingo that both Michelle and I talked a little bit about, how are you working with newer programs for quality measurement like ACOs, like models for comprehensive care in Alabama?
We don't have currently any relationships with ACOs from a payer standpoint. We do have several provider groups within our network that have developed their own ACO-like models. Our programs aren't really considered shared savings, but we do have provider incentive programs for our provider community for those who meet cost, utilization, and quality metrics, and they can see all of those metrics on their patient management resource, and then they can receive a bonus percentage of fee schedule for meeting those metrics. And also, I should point out there, they can see how they perform in comparison to their peers, providers with a similar specialty and attributed patient volume, and I think that drives real good, healthy competition.
Transparency can definitely drive a very healthy competition for it. You know, what successes have you had with integrating clinical data for operations? What barriers have you seen when you try to use it for performance measurement for quality reporting?
Right, so currently we ingest labs, ADTs, immunization registry data, provider supplied and group supplied biometric data, and CCDs, both the structured and the rendered PDF image. And then our next onboarding of clinical data is going to be from the Da Vinci use case data exchange for quality measurement. It's going to be our next onboarding of clinical data. As far as barriers, I would say our number one barrier to even reporting ECDS, we're the slow adopter, like Leah called it, is that our certified HEDIS software vendor has a totally separate file layout and file submission process for ECDS data. We're literally going to have to duplicate the data that we send them now for traditional reporting into a new ECDS layout. I've heard that other HEDIS vendors, just flag or switch, have a switch for their data that they're already sending that flags it as ECDS, meeting those requirements. And I think if that was the case for our vendor, that we would have probably reported ECDS a long time ago. But right now it's not required. So it's very difficult to convince leadership to divert resources away from required activities like STARS and put those resources on optional things like ECDS. But now that there is an ECDS component to some traditional measures, I think health plans are going to pay a lot more attention to those. But there still is an unknown lift. Leah mentioned parallel reporting. I think it would be helpful for our plans to know, is the investment in ECDS going to get us 4 hits, or is it going to get us a 4% increase on a STAR measure like colorectal cancer screening? So I think plans being able to see benchmark data, what do your rates look like in that traditional plus hybrid or a traditional plus ECDS, would help us make a decision as to if that is where we are we ready to make that investment. Sometimes the unknowns, we joke, mean no. So I think knowing, we need some time to benchmark that data over time and see what that lift may be and determine if really that's where our options go. But I do want to say a big barrier, I think, to our eCQM adoption has been that file is in a QRDA, and again, as a plan that's very reliant on vendors, our value-based payment vendor that runs those measures for us can't ingest a QRDA. So we can use it for HEDIS, but we couldn't use it to close gaps on the provider side, as those are more of the HEDIS-like or now allowable adjustment. That vendor doesn't take QRDA. So I think a big barrier is our reliance on vendors.
And the QRDA is a construct from HL7
yes.
for reporting specific data on a particular patient or an aggregate that has the clinical information related to that. So if it's a colonoscopy, it's going to be their colonoscopy on this date for that, just for the audience. How do you deal with a member that's seen by many providers? So you've got this influx of data. You've got data coming from a claims system. You've got data coming from a lab system, other systems for that. Leah talked about the 4 different sources for this, and putting that together with the EHR data.
Yeah, so that's a big pain point for us right now. How do we combine the different sources and trend something over time? Like John mentioned, a member's A1C, HEDIS tells me that as of right now, they're in control, or as of right now, as the last time that we processed measures, that member is maybe out of control. But were they out of control today at a 9, and 2 months ago they were at a 14, well, I would consider a 9 to be an improvement. So how do we combine sources like claims, labs, or EHR data, especially when our claim control codes aren't as specific as lab values that we get? So I do think that's a pain point for us. It used to be that the different EHRs and ingesting that data was our biggest issue. Since we started receiving standard CCDs, we're much better at aggregating that data across EHRs, and I think that speaks to the importance of the standards community. We've really been able to accelerate onboarding by accepting the standard template.
Superb. Awesome.
Yeah.
So John, again, I feel honored to get to ask you a few questions as we get onto this. NCQA gave me a special set of questions here because you've been involved with healthcare for so long.
Why is it fake?
You were an advisor when this whole meaningful use program got started to the federal government. And that program, we've seen a lot of adoption of EHRs. We've seen the big uptick for it. But one of the foundational goals for that program was that we'd be able to do quality measurement and we'd be able to improve the care quality that's provided. How close or how far are we today to realizing quality measurement, quality improvement as a seamless byproduct of care?
Yeah, fair enough. Before we get started, I will answer the question, but before we get started, and I appreciate the introduction of all-knowing, all-seeing, all-powerful, which is what I used to tell my teenage daughters when they were teenagers. Just don't you forget it, young lady. But anyway, in this last year, I've become a grandfather twice. So 2 different daughters, 2 different grandkids, and was told, you got to figure out what you want the grandkid to call you. Okay, I said, fair enough. And grandpa, it's been done. I don't want to do grandpa. So I thought, I've come up with my scheme. So 0 to 2, because I figure this is what you can handle when you're 0 to 2, bub, B-U-B. You got to be able to do monosyllables, particularly with my genetic material. You got to be able to handle that. 2 to 5, big guy with a fist bump, okay? All right? 5 and older, Apollo, god of light, literature, and poetry. So I presented this, and I presented this to my youngest daughter, Teresa, who was the first one to become a mom. And she had finished business school in the last couple of years, and her response was, that's an interesting initial proposal. And I thought, well-trained young lady, they taught you well. I've been sandbagged by a professional man. I know that exactly what that means, a.k.a. this is never going to happen. So anyway, just to let you know, try it out. If some of you are new grandparents or whatever, try it out and see whether you have more success than I did, et cetera. So back to your question. No, I think, in particular, you get to this sort of high bar called seamless. You just push the button and out it comes, et cetera. And you think, well, golly, in a way, the meaningful use stuff, it's, came out 2009, 2010. It's, about a decade old, $37 billion. An awful lot of adoption's gone on. And by the way, the iPhone's now 12 years old, so we've had some real technical advances, particularly in the area of mobility that have gone on. We've got a lot of efforts on your all's part, and to advance all this, continued interest on the part of the federal government, big VC, PE money and investments, the tech giants are stepping in. Golly, how much more throwaway do you want in this particular topic? So how come it's not seamless? Well, it ain't seamless, and it ain't going to be seamless for best I can tell, for years to come here. So if you look at kind of where we are now, I say there are still real issues with the data. It's messy. The data models, when they exist, are all over the place. We got a real problem with it. Plus, we haven't nailed the EHR data, let alone we're going to throw social determinants. Terrific. And then we're going to throw genetics. Terrific. And then we're going to figure out your gut flora has some impact. So we'll throw that in there just to make things sort of stable for a period of time. So we got real issues with the data. We got real issues with the usability. You've all heard the issues, the sort of pajama time. It just takes too long to do some of these types of things here. We've got issues where the interoperability is limited. Some progress, but it's still rather limited. And we've got issues where most providers, frankly, haven't, quote, installed these things, but they haven't really changed the practice as a result. It's sort of like I put new plumbing in my toilet, okay? But we haven't really made the world a better place. So we got real work to do. to sort of all of that has to come together to do this. And it's a form of guerrilla war. It'll be a never-ending series of small, medium-sized victories on the part of an awful large number of people across a diverse set of industries, and that's the way it will be. I think anytime you have complex social phenomena or complex industries like healthcare, like education, et cetera, that's just the way that it is. You just don't change it that route. You can't in lots of ways. Now, that's not to make us pessimistic, it's just to make us realistic about what we can actually do here. Now, you can still say, well, within that context, why don't we go after specific measures? And I say, we'll jury rig this, we'll get a data model there, et cetera. Fair enough. We can do that. And you will get data, and we'll still have to learn how to work with, clinicians and how to use this data. We still have work to do on making the technology easier to use. Maybe it's voice, maybe it's sort of a combination of machine learning and natural language processing to pull structure out of unstructured stuff. We will continue to do all that. So we'll make progress. It may be a little idiosyncratic, it may be a little jury-rigged at times while we continue sort of the broader movement of the landscape. So, long-winded way of saying, I think we're a ways from seamless. In fact, seamless may be a little unfair and a bar that is unrealistic to have happen. So anyway, and there's part of me that actually believes that it's the generation that will succeed me, because I'm a grandpa now, that will carry this across the finish line. It will take that much time. So there's a way to really uplift your spirits in all this conversation.
No, I think about that, and I love the guerrilla warfare analogy, because what EHRs do is it creates potential, potential energy. It's creating kinetics and creating the actual movement of this process is going to be a long fight. It's not going to be done overnight. One of the things I've been heartened to hear about from CMS, both nationally but also even just in the last hour for it, is how interoperability and clinical care quality aren't thought of separate, disparate things. They actually were at one point, which is you had a paper process, and that's how you did quality, and then you had interoperability. You sent something to an HIE, you're hooked up an HL7 feed, and you hit that. We know that patients don't receive care from just one provider or just one EHR, even if it's Cerner. So they have to be considered together for interoperability and quality. How valuable is the longitudinal record in building that picture for quality of care?
Yeah, I think, a couple of things. One is I'm actually finishing up this article on what can we learn from the interoperability efforts of other industries. So if you take construction and retail and financial services and travel, what can you learn? And one of the things you actually learn is that very few industries actually have anything resembling interoperability. It's just, we're actually rare. Lots of financial services and travel. It's actually kind of interesting to be rare. So anyway, we ought to beat on ourselves to get progress. We ought to be careful about beating on ourselves as if everybody else is doing it but us. It's not quite the case here. What's going on here? I do think there's obviously value to interoperability, which is more than the quality measures. You can say, you help the clinician know what's going on here, broadly speaking, and the patient. You can reduce unnecessary testing, sort of drop the cost of a variety of things like that. You can be more rapidly report particular outbreaks or this, that, or this. So there's a range of things that interoperability can bring, some of which are related to quality, but not all of them are related to quality. And similarly, in the quality realm, not everything requires this longitudinal view that goes on. So this fact that I might be notified that a patient of mine is in the hospital, that's a very transient, short-term set of interoperability. It's a huge quality, thing is to know that and to know how to follow up. Similarly, if I'm measuring quality in the ICU, well, I got a pretty short temporal boundary, probably, a couple of days we do a good job. Or an inpatient surgical procedure, so, pretty well-bounded set of things that sort of constitute what I need to know to do quality. So there is clearly this, if you imagine one Venn diagram of interoperability and another quality measure, there's clearly an intersection of the two that needs to occur for us to occur. I think interoperability is complicated. One of the things that's pretty clear when you look at, well, when it does succeed in other industries, why? Why does it succeed, or why does it fail, or just not happen at all? And obviously you got to have standards, et cetera, but there are two major things. One of which is a governance model in which the participants in the industry are brought together to solve the issue and actually show up to solve the issue in a real way. And you can argue whether we actually have that in this industry. You have pieces, there are people doing this and people doing that, but this is the place where people resolve banking issues, for example. The second, the business case. There is a real rationale to show up and to do it and to put your competitive sword at the door, and it ain't quite here yet in healthcare. It's getting there, but it isn't quite here yet. So anyway, I think the two are fused and critical to each other. They're not wholly, an overlap of a union of 100%, but nonetheless critical.
Absolutely, and the quality measurement programs can create those business cases, but you have to realize the Venn diagram exists.
Yeah, the business case, to implement the business case, you need the quality measurement program. So you actually have to have the business case, and then this stuff will come out, but yes.
So we heard from Leah, from Jenny about payers need to manage HEDIS and need to transition to ECDS and things that need to be done from that perspective. Drawing on your background from providers, you think about this other emerging set of programs that are oriented around ECQMs and the provider-oriented measures for it. Do these programs need to converge?
Yeah, I think if you say, look, at the end of the day, there's a whole bunch of folks who have great interest in the health of a person and the health of a collection of people here, et cetera. And they want to sort of understand that, make it better, or this, that, or the other. You say, well, of course, we need a common set of data. We need to know clinically what's going on. We need to know social determinants, what's going on. We need to know, the sort of device stuff. We need a whole range of stuff. And we ought to see if we can get a convergence and agreement on what that set is and how to define it. And you all know, and Michelle pointed out how hard that is to get that kind of agreement and consistency. So you have to go there, because otherwise you obviously have the risk, which we realize, is that coming out with a different set of data, I see it differently. People see it differently because of the data that they collect. Now, how do you resolve that? I think part of it is the federal government's got to be a big player in putting people together, and frankly, it's the gorilla has the ability to force certain issues that not all other participants have to happen. You can see more localized phenomena where providers have their sponsored health plans. They're in a position to do that. And similarly, we have health plans that have a bunch of providers under their wing. They're in a position to do that. And it could be a sort of common governance model. It could be a joint venture model and things along those lines here. So I think there's two ways you do it. One is you have local efforts to do this because there's local incentives that have come together. And the other is you have industry-wide efforts, of which NCQA can and is part of it. But I think at the end of the day, if the federal government isn't sitting at the table, it's really hard to make a lot of progress.
So back several years at Partners, we talked about being able to do clinical research at 1/5 of the cost and 10 times the speed using EHR data over manual abstraction, manual processes for it. Does that same ratio apply for quality measurement? How do we get there?
Yeah, I mean, with the thing I was referring to is actually some work that a colleague of Ken's did, John Brownstein did, where he looked at emergency room data at the Brigham and the Mass General, where the admit diagnosis was heart attack, confirmed admit diagnosis. And essentially what was very clear, you could pick up the Vioxx signal. Very clear, it was in there. Now, how long did it take John to do that? Well, golly, he's a bright guy. About a month, 1/3 of the time. Now, if it wasn't so bright, maybe 2 months, half time, whatever. The point is, wow, that was really fast and really innocent to pick up a signal. There was a signal of something was hurting people, or there certainly was a signal of elevated heart attacks that went up and dropped back down to baseline, et cetera. You could also pick up signals of comparative effectiveness. Wow, treatment A really is better than treatment B. Or you could pick up signals that says, I know what the drug was intended to do, but golly, look over here. There's other beneficial impact that's going on here, et cetera. So I think what we'll see this kind of interesting, we have the, quote, old way of doing quality measurement, part of which was mentioned, in Michelle's talk. Yes, abstractors, you do this, you do that, et cetera. And in a similar way, with the old way of doing clinical trials. We go off and do this, we recruit a bunch of people, and the way we go here. So you got the old way, and there's all kinds of issues with the old way. And you got this promise of, quote, the new way, the big data new way, coupled with fancy, algorithms and methods, et cetera, that are going to go off and do this. Now, I suspect that what will happen is some of the ricketiness and the inefficiency of the old way will get replaced by this. We could perhaps extract from the data, because we have a whole bunch of it now, the structured terms that normally were being abstracted by a human being. So there will be some efficiencies that are created here. But the main thing that will happen is the combination of the two methods will leverage each other. So we use hybrid measures in one way when we talk in NCQA, but there's another hybrid here, which is a hybrid of the old and the new working together to do this thing. So what might that look like? We'll say, I have a measure of interest here. Can I simulate it over here? Sort of simulate the measure and the data and the impact, et cetera. I have a trial over here. Can I determine whether that is occurring, can I sort of model the trial in silico, so to speak, here? So what we will learn collectively is how best to marry the sort of big data efficiency, signal detection ability, but the signal may not be strong or definitive enough to say, I really got to pull the drug or the device. And by the way, I got to get it out of here or this, that, and the other. Or that I'm going to reward you this amount of money based on your performance. It may not be that good where you can really get away with that, et cetera. So I think that's what we'll wind up seeing here is you got to play in both. They'll fuse in a way, and they'll fuse one way here and another way there, but nonetheless, there will be the bringing together of both approaches.
So this afternoon, we're going to break back out. And I know that you've been in one of the tracks, participating and listening and joining the conversation for it. What would you ask of all the people out here that will go back out to the 5 tracks? And what are the things that you need to get, or you want to see, or you think would be best to get out of the Digital Quality Summit to continue to advance this transition?
Well, I think, there's, I was said in one of the tracks, and I thought, wow, there's a lot of these things, everybody in the room knows more than I do about a particular topic. That's the nature of my existence. That's why I went into management, because it's safer there. So I think, one of the things is there's enormous value of you learning from each other. Just phenomenal value that occurs, whether it's this group or a bunch of CIOs or whatever it might happen to be. So I encourage you to take advantage of that learning experience. And it's not just things you pick up and learn, but it's people you meet and cards that get exchanged so that when you got an issue a little bit later on, you know who to call, or you call a colleague like that. Incredibly valuable. And if you do nothing but that, this will have been a success, along the way here. I also want, and I realize that we're sort of moving to this realm, for example, of large data. It was in track 2 in the discussion of the OMOP standard, which you brought up earlier this morning. And the Odyssey effort, which is Odyssey is an acronym for the Observational Health Data Science and Informatics Initiative, which is a really neat approach to bringing lots of data together, 4 different countries, 11 different organizations, 250 million people to do this kind of, observational, can you look at cruddy data and see things, et cetera. So I also encourage you, while you solve the issues confronting you today, because at the end of the day, you got a day job and you got organizations worrying about it today, that you take the time to begin to think about, well, where is it going? And what might it look like? And how do we, or me, in my organization with my colleagues, help advance that particular conversation? And I think that's always the role, is solve today, but on the other hand, maintain a heads up enough that you will see tomorrow. Because the thing about tomorrow, sooner or later, it is today. And so the ability to sort of anticipate that is worth a lot.
Thank you, John. So I want to give a heads up here. Ken will be the last panelist. We're going to have time for questions. So now is a good time to start scribbling down some notes and get ready for the mics here in a little bit for it. Ken, you and the team at Harvard, have been instrumental in the advancement of the app ecosystem for health IT. Namely, it's Smart on Fire, or the substitutable medical applications using reusable technologies on the FHIR standard, Fast Health Interoperability resource. That's similar to how app stores empower all the things you can do in a phone for it. When you think about quality measurement, what functions do you think are best done by the EHR as they exist today, kind of big sets of software, versus that app ecosystem that's emerging?
That's a great question. First, I just want to say that when you first took that scroll out, I thought you were going to open it horizontally and inform us that John is also secretly a practicing Talmudic scholar. Okay. So anyway, so the app store model that extends EHRs in a very specific way through what we called, when we initially wrote it up, sort of an iPhone-like model of substitutable apps, so that you could add or delete functionality from an EHR that is also available in some kind of an app store or app gallery or app directory. The iPhone, as John just reminded us, when we wrote this up, was only 1 year old. But from the time we wrote the article, at the end of 2008, 10,000 apps for the iPhone. To the time it was published, March of 2009, 50,000 apps in the iTunes store. 1 year later, when we were actually already now funded, based on that article, to design this API, more code had been written for iOS than any software project in history. And so we caught this hockey sticking phenomenon. And there is now the capacity to add, in a sense, sort of above the fold, a set of apps that are physician or patient facing or researcher or quality officer facing that extend EHR functionality. And those apps can be produced by the EHR vendors themselves or by a startup company or by a very large tech company. The first major user of this technology has been Apple, to use it at scale, where they connected the health app to 500 health systems using the Smart API. And that was there because of some regulatory innovation on the part of the ONC and CMS. And now the question is, how do we use that for quality, right? So I'll give an example. So right now we're trying to do some measurement across multiple children's hospitals. And we have different electronic health record systems. And so there are ways to implement data input by clinicians in deep inside the workings of the different EHR vendors. But one way to potentially, for example, collect completely uniform data, send it to a registry, store it in the physician notes, bring in external data as well in a way that's uniform across different organizations, would be to use these apps that are sort of above the fold. The R, which is reusable, tells us that the same app can run on different systems. And there are increasing numbers of commercial apps, the Meducation app, the Visual DX app, that do run on multiple different systems with essentially an unmodified application. So one area to think about for quality measurement is where you want to take the same measure and you want to be able to easily modify it in the future. So updating an app is simpler than going in underneath the hood. One of the limitations right now that we're all working on together is about writing back into the EHR, and where does that go? The smart ecosystem right now is better at pulling data out of the EHR into a web app, an iOS app, or an Android app. It's not quite as nimble in a uniform, standardized way at writing data back in, but we have a number of ways to do that for now. There's good old PDF. There's HL7 2.3, which is a potentially perfectly good way to put data back into the EHR, and there's increasing write capacity within the standards.
So there's definitely a lot of excitement around FHIR, Fast Health Interoperability Resources, and you've been where the rubber meets the road for as that standard really first took its footing and made its way into the community and then eventually into HL7 for it. What's your perspective on digital data and how that's going to flow out of EHRs using APIs and using FHIR? What are the timelines? How quickly is this all going to happen?
Well, that's the question right now. So, we had some conversations with members of Congress and the Senate a couple years back, and there ended up a few sentences requiring an API in the 21st Century Cures Act that gives access to all elements of a patient's health history. And they say in there without special effort, which essentially means it better be sort of standardized and turnkey. So that language, along with other language about things like information blocking and and patient reported out, there's a lot of stuff in the 21st Century Cures Act, is getting now detailed out very carefully in two big documents, these two proposed rules, one from CMS and one from the Office of the National Coordinator of Health Information Technology. And so those rules were open for public comment, and now there's the sort of response to that public comment period. There's a general understanding that, and we'll see how this plays out, that potentially as soon as the end of the year, those rules will start to get finalized. And then there will be a period of time that, probably about 2 years from then, from the end of this year, to implement a bunch of these things. Some of the provisions may go in very quickly. Information blocking may happen much faster than that. The things that require technological work will happen over that period. The good news is that there's been an awful lot of work that's happened already in this direction. So all the electronic health record vendors worked with HL7, with our team from the SMART team, with Mickey Tripathi's group to drive capacity that's uniform and standardized into electronic health records, including the SMART API through the Argonaut group. Yep. So the other way to slice and dice your question is to think about two modes. One is the traditional sort of SMART API, SMART on FHIR API, which is one patient at a time. The SMART on FHIR API lets you extend your EHR view of that patient with apps, or if you're the patient, your view, your portal view turns into an app view. That's the one patient at a time mode, and that's a pretty mature technology right now. There's a newer technology called bulk data export, or we call flat fire, where we're looking at how do you get whole cohorts out of the EHR in easy ways, sort of a coarse query to initially get that data set out, and then you put that into an analytic engine and you slice and dice it in an analytic engine nearby. Again, the Argonaut group has taken forward that project and actually done an implementation which ended last year. And there's a number of demonstration projects going on. CMS has already begun to provision its data to ACOs using this bulk data standard, and they started to do that when it was really still very much of a draft standard. There's a lot of excitement on the CMS side. That's the claims. And then the electronic health record data where there's a number of interesting experiments going on about how to bring that out. And it would be really great to see that become also a standardized feature of EHRs. And I refer to that as sort of push-button population health, so that you can rely less on the ETL teams, because the ETL teams that we need to do these things now are very specialized, expensive, and hard to hire. And it would be really nice, and you never get the ETL processes happening at the practice level generally, or smaller hospitals. So the big hospitals, we can handle it, we do it, we wouldn't need to really fix it, but if we really want to get the broad swath of the healthcare system into this mode, I think it would be a great capacity.
You know, just picking up off of that, you're right, scale requires standards.
Yes.
It requires ways that you can do this en masse without putting more people at the problem for it. I want to highlight the two rules that Ken just mentioned there. Stay tuned to the channel for CMS and ONC. Those rules were proposed rulemaking in February, March. End of this year, maybe early 2020, we'll begin to see how the final rulemaking for those shape up. We know data quality, which is a whole track here dedicated at the Digital Quality Summit, is necessary for accurate quality measurement. Clinical data from EHRs don't have the same feedback loop as data from claims, data from billing. If you don't put in a field that's on a required claim, you're not going to get paid. When you're missing that onset date for that diagnosis in a clinical chart, life continues on. What tools do health systems, do health information exchanges, do health plans and payers need to ensure data completeness?
Yes. Well, I have a two-part answer to that question. One is that when data are used by an organization, and when those data then are incomplete or don't work for the processes within the organization as it's using them, that gets noticed.
Yep.
When data just sort of go in and then are used by someone else, probably doesn't get noticed as much. So the two-part answer is, number one, I'm optimistic that as we start to use these data more, particularly around payment, that organizations will start to develop those feedback loops, because they're going to have people within there that are looking at performance and that know these things need to be measured. But part two of the answer is a more complicated calculus, because if the data are being entered by, let's say, clinicians, and we don't want to overburden clinicians, but we certainly want to find that intersection between what the clinician needs to document and what we want to measure. Now, I would argue that there is got to be more give and take between those two desiderata than maybe there is now. And that's no one in particular's fault. These have been processes on separate tracks. But what I'm saying is, if we put those two tracks together and we don't choose metrics that include information that nobody wants to enter, as valuable as they may be, those may be the lowest hanging fruit. And secondly, if we can decide on what needs to be in those notes in such a way that it's driving clinical care, but also clinical quality, then I think we can improve our documentation system and have the metrics go. So I think I think we need to start to bring these processes more together. I think they're still on separate tracks.
Value-based care as a basis to get interoperability, but also data quality. It's that economic incentive, the use that's going to push us forward in that data domain for it.
Yes.
So last question here, and then we'll invite the audience to ask questions for the panelists. We've heard from the other panelists about how auditors, how payers, how EHRs approach quality measurement. And I'd like to ask you, what NCQA, what HL7 can do to support this from a patient-centered perspective. We often get bogged down in programs, and we have the acronym kind of soup that we talked about earlier. What's the largest thing that you could see coming from this conference to advance patient-centered care and patient-centered quality care?
Well, so patient-centered care has, different meanings in different contexts. Let me take two of those meanings. One is that the patient is actually the one sort of using the technology here, in this case, sort of patient-centered technology. And I think that these APIs and the rules are very much enabling of patients getting copies of their data. Apple brings those data onto the phone now. I've heard folks in high levels of authoritative positions say that clinical notes and things will be coming across those APIs if the regulations go forward in the way they would like. And now the patient has a treasure trove of computable information in a computable format on a computer in their pocket. So one answer to that is that we can start to create applications that are addressing populations of patients and individual patients, both in their relationship to hospitals and also outside their relationship to hospitals. From a sort of patient-centered care perspective, where we're really talking about care that that is driven by shared decision-making and patient goals and objectives and outcomes that matter to the patients, I think we also, again, because we can bring patients into this loop of measurement and reporting as well, and that their phones can generate data passively that may be useful for this enterprise, that we can get to much better measures of functional goals for patients rather than just moving biomarkers a little bit, which has been our traditional clinical trials mode. And so we have the opportunity to really look at what matters to patients. That'll happen first in clinical trials and is happening in clinical trials as sort of add-on endpoints within these clinical trials. But soon enough, those kind of digital biomarkers, I think, will also become important for driving care forward in ways that are going to be much more aligned with patient goals.
Awesome. Well, first, let me say thank you to each one of the panelists here for taking the time. We've got about 10 minutes for questions. Does that sound about right? I know we've got a break coming up afterwards. All right, I see one. All right, go ahead. Introduce yourself, please.
Yeah, can you hear me? Yeah.
Yeah.
My name is Terry Kitchen. I work for HCSC. So to Dr. Mendel, I want to ask you a question about specialist measurement. So all the measures that we seem to just spend all of our time on are all around PCPs. And I have been tackling for 3 years now, trying to figure out what's the best way to measure specialists. And people misuse PCP measures as a proxy for, macro put together a lovely list that nobody can measure. There's a lot of measures in there that unless you have the clinical data, you can't do it. And it honestly takes clinical interpretation when you look at a medical record of a cardiologist, for example, to be able to know what the right exact data is that would be the element that you'd need to do the measurement. So where are we going with this?
So that's a great point. In some ways, the low-hanging fruit of primary care-based metrics, like was a blood pressure measured for someone with hypertension, is both extremely important, but also could be distracting from in parallel addressing more complicated measures in specialist care that will address, for example, some of the most expensive patients, right? How are we selecting and using biologics in rheumatoid arthritis, for example? And how are we measuring the quality, and do we even know enough to identify what the quality measures are in those domains right now? So for one thing, this is another area where we're developing the right input in clinical settings is important. So one of my faculty members works with an organization called QDRA that has basically almost all the pediatric rheumatologists in the country collaborating together, and about half the kids with pediatric rheumatologic conditions are in their registries. They're changing the way data are entered. They're defining the way the patient-reported outcomes are happening. They're actually standardizing care into these consensus treatment protocols across their whole profession. And because it's such a small profession compared to others, it's a great place to begin doing some of these things. So I think the specialists do need to get together, and the technologists and the standards bodies need to be able to support them with at least the basic structures to be able to collect those sorts of information. But I think it's an incredibly important area for quality measurement, and just defining what the quality is, because they're working with consensus now to define these things in the pediatric network. But we can soon get backwards, and this is the era of deep learning, right? So in deep learning, you start with the diabetic retinograph, right? And then you work backwards as to how to identify the stage. The deep learning algorithm does that. I mean, in some ways, if we know the outcomes we want, and we have all this data across multiple data sources, we may be able to actually use deep learning models to learn the quality metrics. And some of those quality metrics might even be in sort of black box algorithms, right? So I think we're going to be ending up approaching this from multiple different angles.
A different way to think about quality measurement. Go ahead over there.
Linnell James, Blue Cross Blue Shield Association, along with John Glasser at Cerner, who's one of the founding members of Da Vinci, and Jenny, who's with Alabama, who's also one of the founding members, and the association is one of the founding members. John, earlier you mentioned that one of the challenges is what are the use cases that get people to collaborate. So Da Vinci, it's a collaboration about value-based care, and it does include, as Jenny mentioned, digital exchange for quality measures and care gaps. I guess for you, Ken and John and Jenny, are there some other use cases related to quality measures that need to be added to the existing 18 that Da Vinci is chasing right now?
Why don't we go with Jenny first? We'll go that way. Yeah.
We have so many use cases in the pipeline. I'm not sure I really want to add more right now. There are only so many hour time slots in a 40-hour week these days. So I think from a quality measurement perspective, we're kind of rolling through them. We really amped it up with a data exchange for quality measurement. We focused on medication reconciliation post-discharge. That was a high priority measure for our plan. I think it went very well, and once we wrapped that up, we went into colorectal cancer screening. I think when that wraps, we'll really start to have a framework for what screening measures look like in those use cases. Gaps in care is the next one that we're really excited about, being a part of. I'm not sure what's next. That's a little above my pay grade.
Yeah, I don't know enough to give you an answer, although I'm management, so I can make stuff up and sound confident in doing so. I think a couple things. One is, actually, as you look at the financial services, which often sort of touted as, golly, if only we were like them. I go anywhere in the world, get my money from the machine, et cetera. We ought to be like that. You say, yeah. On the other hand, if you go into you sort of go into your Wells Fargo account and say, I want $20. Wells Fargo says, you only got 10. I'm going to reach into your Bank America account, grab the 10, bring it back, and serve it up to you. That doesn't happen. Why? Because the competitive juices prohibit that from happening, et cetera. So when you get these things that sort of everybody agrees on, and there are certain things they won't agree on because it's just too dangerous for whatever set of reasons competitively, you see three things. One is the business case to me as an individual organization is very clear. It's clear what's in it to me. It's also clear for me to get my gain, I need you to get your gain. Otherwise, I wouldn't bother you. It's a pain in the butt to collaborate, et cetera. So, and also what's clear to me is the more of you that get your gain, the greater my gain. It's sort of like email. There's a network effect here. So I don't know of the 18 if there is a 19 or 20 or whatever, but essentially whatever the proposals are, you say, can I hold it up to that sort of litmus test? Gain is clear. There's I need the others, and I need a whole lot of the others in order to get that. And I think those become candidates for these kinds of things. So anyway, Ken may know more specific things that he might add to the pile, but I don't.
I would say, I'll make a more meta comment, which is that there is a bandwidth issue because, if you look at, for example, the Argonaut group, there's generally like about 10 great projects proposed at the beginning of the year, and then there's a vote, and then a much smaller number are selected, but then they really get done. And so, for better or for worse, the process right now is that we have a limited group of sort of companies and designees from those and technology development cycles, and the ball is really moving forward. So what I would urge us to do, I know Argonaut better than I know DaVinci, but I've been impressed with the use cases in DaVinci, is that for both groups, we select what we can realistically also get done in that time frame. Now, what we can realistically get done on measurement will also depend on how good we are at getting large data sets into analytic engines. And so, there's clearly going to be data structures that sit near the electronic health record. So John and Cerner have Healthy Intent, very interesting population management system. You can see that the large technology companies are developing FHIR servers, where you could potentially do population health. I think it's too early to be actually doing population health in those, but they're probably looking at that. Once the data are in a highly computable environment, then I think you can slice and dice more quickly. So there's, I think, realism and really understanding these time courses is going to be an important factor in figuring out whether choosing the ones of the 19 to implement first, or developing more is the best source of, as you say, the hour slot meetings during the week.
And I'll add that we operate in DaVinci under HL7's antitrust policy, but I would think the collaboration, my experience with the collaboration among payers has really been incredible. As outside we're competitors, and really when we get in that space, we're very focused on making the needed changes in the industry, on establishing standards, and I think that shows in the progress that we've made so far.
Absolutely. Credit to Chuck and everyone at HL7 for creating that environment where both the HRs and also payers can work with the competitors to get things done for it. I think we got time for one more.
This is Junqing Liu with NCQA. I'm hearing that there are really different steps, starting from data being entered by the clinicians. Next step is being accessed by providers and payers, etc. And last step maybe is being consumed for different purposes, payment, quality improvement, etc. So the starting point, we're all eager to realize the benefit of accessing this data and having them documented. I'm thinking that the starting point really is to have the data being entered by the clinicians at the point of care, in structured fields maybe. So, and if you read the news articles, we hear that physicians spend 40 actually 60% of their time in the office on paperwork. Even when they're in exam room, 40% of their time is spending on doing EHR documentations, filling out the forms. So the question is, what's the thinking around having other healthcare specialists, other healthcare professionals, maybe not the clinicians, being paired up with the clinicians and doing the paperwork. For instance, when they are in the exam room, people who may be trained, they know the forms well, they can do the job more efficiently. To have the doctors focus on what they're trained for, which is seeing the patient.
So the idea of getting mid-levels and having ancillary staff involved with this burden, this burnout that's happening from administrative overload. Why don't we do John first to talk on that, but then also Leah talking just a little bit about how you think about the verification of data from ancillary staff.
Yeah, I mean, I think in a way, it's not the time percentage, because if you say, how much time does a Wall Street trader spend in front of a screen every day? 100% of their time. How much time does a travel reservation spend in front of a computer? 100% of their time. So it's not the time, it's the fact that this has high externalities. I'm spending time, there's nothing in it for me, okay? In fact, it's a drain from other things. So it's the externality problem. So we ought to be clear that that's kind of what it is. Now, that being said, I think there are things you want to do to reduce the time. And so there's voice and a variety of technology stuff that you can do to reduce the time. To your point, you say, who should be doing some of these tasks? Following up on the emails, the prescriptions, should the doc really be doing it? Or the gaps in care? Who should really be following up on this? Should we ask other people in the practice to go off, including the patient, to do a number of these types of things here? Can we incent them such that if their quality scores go up, which is a whole part of this value-based care stuff, such that the time is compensated for along the way here? So I think there's a use in other practices, technical means along with compensation means, and the key thing is to change the equation. So when I say, what's in it for me to do this, there's a clearer answer than there is right now. Because I'm not always convinced it's the time, because other occupations spend more time than that, but it's clearer to the trader what's in it for me.
So Leah, as you think about using that data, maybe data collected through NLP, maybe data collected from a mid-level for it, how does that compare? How does that feed into the process?
Well, from a reporting perspective, hopefully folks took a look at the allowable adjustments that were put out last year in the allowable adjustment value set, and there were some new types of codes in there, SNOMED codes, RX norm codes. Those are built into the process within EHRs already. So if you took a look at the value set this year, which if you haven't, I would highly recommend that you do, because it's actually pretty exciting. There are over 42,000 SNOMED codes in the value set directory to report HEDIS 2020. So those are codes existing in EHRs based on services that are being rendered. So it's somewhat of a coding system that we can hopefully leverage to report performance measures and not necessarily requiring extra data entry into an EHR. It's already there. Mining that, extracting that, that's what we need to focus on. So I don't think we're necessarily in performance measurement saying let's put more burden on a physician. Nobody is saying that. But let's take advantage of what we already have. And you had asked earlier, how do we get folks to start doing this? Those 42,000 SNOMED codes are not limited to ECDS measures or the parallel reporting measures. It's really across all of the HEDIS measures in all of the domains. Things from CAP, AAP, which is our access to care measures, all the way to care of older adults and getting functional status assessments out of the EHR and SNOMED codes. So to kind of get to your question, I don't necessarily think that we need to have anybody that's at the rendering side do additional work. The data is there, it's using it and getting it out for performance reporting.
Well, join me one more time in just saying thank you to our panelists for that. I think this has been a tremendous discussion.